Hello everyone. Today we will be going over the second section of psychological disorders in chapter 15. So to begin with, we want to broadly talk about the anxiety disorders, or the disorders that fall under the anxiety cluster. And so these include generalized anxiety disorder, or GAD, phobic disorders, panic disorders, and obsessive-compulsive disorder, or OCD. So with these disorders, all of them have several symptoms that they share in common, and as we go through the slides, we'll break down each one and talk about what they actually look like in terms of symptoms and prevalence rates. So more generally, when we do talk about anxiety disorders, these are disorders where anxiety is the predominant feature, so that worry and that stress, and it's excessive and it's very frequent or recurrent. And so anxiety can be adaptive or maladaptive. So we all experience anxiety to some extent, but oftentimes we're able to pull ourselves out of that mood, or to tell ourselves to stop worrying about it, and we can stop worrying about it in some situations. But if anxiety sticks around for a long time and almost consumes an individual's thoughts and their behaviors and their emotions, their actions, then it may be considered maladaptive. So when we consider it maladaptive, it's disproportionate to any real threat that's going on, so they don't have like a big test coming up, or there's no imminent danger towards that individual, then they may experience a maladaptive type of anxiety. And so what I want to talk about more specifically is generalized anxiety disorder. And so this is a disorder that's characterized by chronic and excessive worry accompanied by 3 or more of the following symptoms. And so when we talk about this, it's generalized because the unrelenting worries aren't focused on any particular threat or specific situation, but they are exaggerated and irrational worries about a number of things and not something specific. And so restlessness, fatigue, concentration problems, as I mentioned in class, all of these things begin to become more of a vicious cycle where you don't get sleep, and then it kind of just steamrolls from there. You start to experience all these other symptoms. And so this isn't just one day that this happens. This is occurring over a longer period of time that eventually causes distress and impairment in the individual's life, whether that's social, at work, at school, and just causes them distress and impairment for themselves as well. So roughly about 5% of North Americans experience generalized anxiety disorder. Phobic disorder, specifically what we want to bring up or start with, is the social anxiety disorder. And so this involves an irrational fear of being publicly humiliated or embarrassed. And so this can be restricted to situations such as public speaking, eating in public, or urinating in the bathroom. And it can be generalized to a variety of social situations that involve being observed or interacting with unfamiliar people. So it doesn't have to be one specific situation, but they are more focused on being negatively evaluated by other people. And so people with social phobia try to avoid situations where unfamiliar people may evaluate them, and they experience intense anxiety and distress when public exposure is unavoidable. It can develop in childhood, but typically emerges between early adolescence and 25 years of age. Many people experience social phobia, about 11% of men and 15% of women. Actually meet criteria for this diagnosis at some time in their lives. Even higher rates are found among people who do not have a higher education, have low incomes, or both. So unlike the generalized anxiety disorder, or GAD, phobic disorders are more specific to certain situations. And so this is also encompassing that social anxiety disorder. With phobic disorders, the DSM describes them as a marked, persistent, and excessive fear and avoidance of specific objects, activities, or situations. Exposure to the stimulus invariably provokes an anxious response, sometimes in the form of a panic attack. So the individual will recognize the fear is irrational, but they can't prevent it from happening. So the situation is avoided or endured with intense anxiety and distress, and disrupts their occupation, so their job, academic functioning, so completing schoolwork, or social functioning, so visiting with family and friends. And so within the phobic disorders, specific phobias are irrational fears of a particular object or situation, and these fall into the 4 categories that are seen on the slide: animals, nature, natural environment, situations, or blood injection injuries, and also can fall into other types of phobia, including illness or death. The specific phobias may include fear of dogs, cats, rats, snakes, spiders. In terms of natural environment, heights, darkness, water, storms, situations, bridges, cars, elevators, any closed spaces, blood injections and injury. So you can think of a needle phobia. All of these are encompassed under that specific phobia. So specific threat that the individual is experiencing anxiety related to that. And so 11% of people in the U.S. will develop a specific phobia during their lives, and sometimes for unknown reasons. The risk seems to be increasing in younger generations. With the exception of fear of heights, they are more common among women than they are for men, with a ratio of about 4-1. So research has shown that both humans and monkeys can be quickly conditioned to have a fear response for stimuli such as snakes and spiders, but not for neutral stimuli such as flowers or toy rabbits. So we see that with neutral stimuli like flowers or toy rabbits, it would take more trials, repeated trials, for the individual to be classically conditioned to fear that stimuli. Similarly, research on facial expressions has shown that people are more easily conditioned to fear angry facial expressions than others. So phobias are particularly likely to form for objects that evolution has predisposed us to avoid. So this idea is also supported by studies of heritability of phobias. So if you have someone that is in your family that is very close to you, your parents, your grandparents, your aunts, your uncles, that have been diagnosed by a psychologist or a trained physician, you may have a greater likelihood to develop a phobic disorder. Temperament may also play a role in vulnerability to phobias, so infants who display excessive shyness and inhibition are at an increased risk for developing phobic behavior later in their lifetime. Neurobiologic biologic factors may also play a role. Abnormalities in the neurotransmitters serotonin and dopamine are more common in individuals who report phobias than those who do not. Also, individuals with phobias sometimes have abnormally high levels of activity in their amygdala. And as you recall, the amygdala is especially important to processing emotion and fear. And the environment and upbringing likely is also contributing to the development of phobic disorders, where we have seen time and time again that fear can be classically conditioned, like in the case of little Albert. So here we have panic disorders. So people who suffer panic attacks are frequently overwhelmed by fears that are intense, but in the absence of any real danger. Panic disorder is characterized by those that are experiencing recurrent panic attacks or having significant anxiety about having another future attack. Most people experience a panic attack at least once in their lives, usually in young adulthood. Approximately 22% of the U.S. population reports having at least had one panic attack, typically during a time of intense stress. Only actually about 3.5% of the U.S. population actually meets diagnostic criteria for panic disorder. Next, we have another complication of panic disorder, and this is agoraphobia. So agoraphobia is a specific phobia involving a fear of venturing into public places. Most people with agoraphobia aren't scared of the public place themselves, but of having a panic attack in a public place or around strangers who might view them with disdain or fail to help them. In some cases, people with agoraphobia are unable to leave their home for years. Prevalence rates include about only 3.5% of the U.S. population actually meets the criteria for phobic disorder, but of that 3.5%, only 3/7 actually meet criteria for agoraphobia. So very, very low prevalence rates. In terms of causes, family studies suggest a modest hereditary component, so heritability in terms of your parents and your grandparents passing it down through younger generations. We also see physiological arousal obviously plays a role in phobic disorders and agoraphobia, so pounding heart, sweating, symptoms such as those. And so here is the mini practice that we talked about in class, and so it included it in the presentation so that you can also practice as well. Next is Obsessive-Compulsive Disorder, and so OCD is repetitive intrusive thoughts or obsessions and ritualistic behaviors, compulsions, designed to fend off those thoughts or those unwanted thoughts that interfere significantly with an individual's functioning. So anxiety plays a role because the obsessive thoughts typically produce anxiety and the compulsions are designed to reduce it. But the obsession and compulsions of OCD are intense and frequent. The person will also realize that these thoughts and compulsions are excessive or unreasonable, but attempts to suppress them or ignore them are not helpful. In fact, suppression can often backfire and increase the intensity or frequency of those negative thoughts. And so approximately 1.3% of people will develop OCD sometime in their lives, with somewhat lower rates in Asian cultures. Women tend to be more susceptible than men, but the difference is not large. Most common obsessions include contamination, aggression, death, sex, orderliness, disease, and disfigurement. Compulsions typically include cleaning, checking, repeating, ordering, arranging, and counting. So here we move to shifting our discussion into talking more about mood disorders, and specifically depressive and bipolar disorders. And so to begin with, mood disorders are just mental disorders that have some disturbance on the mood, whereas anxiety was more about stress and worry and physiological symptoms. Mood disorders can also have physiological symptoms, but it's more about the disturbance on the mood. So talking about MDD or major depressive disorder, this has a significant impact on the individual's mood. So they're down and depressed mood. So major depressive disorder, also known as unipolar disorder, is characterized by severely mood that lasts 2 or more weeks and is accompanied by feelings of worthlessness, lack of sleep, appetite, pleasure, and all of these are disturbances that we see typical of MDD. And so related to that, we see dysthymia. And so although these individuals may not experience the intensity of these symptoms, they experience the same symptoms but at a less So related to MDD, we see dysthymia, where these individuals may not experience the intense depressive symptoms that individuals with MDD may have. They experience them for a longer time, at least 2 years. And so taking those two together, an individual may experience double depression, where they experience both dysthymia, so a long, arduous time of at least 2 years where they're experiencing these maybe even subclinical symptoms, but in addition to that, they also experience major depressive episodes with that as well. And so here we talk about seasonal affective disorder, which is a depression that involves recurrent depressive episodes in seasonal patterns, so based on the weather. In most cases, episodes begin in the fall and winter and remit in the spring, although we have seen some episodes of SAD in the summer. This pattern is due to reduced levels of light over the colder seasons, and a winter-related pattern of depression appears to be more prevalent in higher altitudes. And so a couple of the examples that we talked about in class were Seattle and also Alaska. So when we're talking about these mood disorders and talking about depressive episodes, they average about 3 3 months. And so without treatment, approximately 80% of individuals that do meet criteria will experience at least one recurrence of the disorder. And so we see the definite benefits of seeking out treatment, whether that's medical or therapy. And so compared to those who only have a single episode, individuals with recurrent depression have higher rates of depression in their families, have more severe symptoms, make more suicide attempts, and experience higher rates of divorce. So rates of depression seem to be increasing again in younger generations. Women diagnosed at rates twice that of men. And so this may we may take into consideration some physiological or biological factors that may explain why we have difference in prevalence rates between men and women. And so hormones may be another possibility. So estrogen, androgen, and progesterone also influence depressive symptoms. We see that women, after giving birth to their child, sometimes experience postpartum depression due to an imbalance in their hormones. And then also when we look at social factors, it's more socially acceptable for women to disclose their symptoms or their experiences as opposed to men. So with biological factors, heritability for major depressive disorder ranges from about 33 to 45%. It's higher for more severe depression, as we talked about with the recurrent depression. And neurotransmitters include norepinephrine and serotonin, but this may not tell the whole story. Just because we are able to provide medication to an individual that experiences MDD, it may not solve the problem. So that's that intervention causality fallacy that we were talking about in the last class. And so also, in addition to that, another biological factor that we have to take into consideration is brain functioning. And so we see these differences in the prefrontal cortex. And these are specific areas of the brain that are involved in emotional processing. And so that definitely has an influence on an individual's symptoms of MDD. Here we have Aaron Beck's helplessness theory, and so those individuals that are more prone to depression attribute negative situations or outcomes to either their internal, stable, or global about themselves. And so internal, it's my fault, I'm no good, instead of just bad luck. So they got a bad grade on a test, it's all my fault, I'm stupid, I'm dumb, instead of thinking it's bad luck or I didn't study as I should have. Stable would be, it's always going to be this way, I'm never going to get an A in this class, I'm not smart enough. So it's stable, it's always a part of that individual. So instead of thinking of this is just a bad time, or maybe I didn't get enough sleep that day, so I wasn't feeling that well and I couldn't think clearly. Global would be, this will ruin my entire life, I'll never graduate from college, I'll never go on to medical school, all of these things. So it's more of a futuristic global attribution that the individual makes, instead of this will only affect this one part of my grade, my overall grade. So depressed individuals, interestingly enough, not only think about the future in depressive ways, but also think about the past in a depressed, biased way. And so thinking about the bad times that have happened in the past, and when somebody did them wrong or cheated on them. So when we talk about the real world and actually look at how does this impact us in the real world, we may already know that answer because we oftentimes see these psychological disorders around us or on TV. But when we talk about its impact on individuals' functioning, oftentimes we talk about suicide and suicide risk. So what we see are that men are more likely to commit suicide than women at all ages. That's men's likelihood of suicide grows in early adulthood, and that white men remain most suicide prone throughout life, with a spike in later years, as we can see on the illustration on the slide. And so oftentimes there's a stigma or a stereotype that ethnic minorities may have a higher rate of suicide in their culture, but as we can see from the data and the research, it's telling us that no, it's older white men that are more prone to attempt suicide and complete suicide and have a higher suicide risk. So here we kind of switch talking about depressive disorders to talking more about bipolar disorder and what that actually looks like. And so with bipolar disorder, this includes a manic episode and also a depressive episode or a low mood. And so manic episodes are these distinct periods of abnormally and persistently elevated, expansive, or irritable mood that lasts at least 1 week, and 3 or more of the following: so an inflated self-esteem or grandiosity, a decreased need for sleep, more talkative than usual, or an increase in goal-directed activities. So with mania, it's almost a really high. So the individual is experiencing grandiosity. They think they are the person and they could do anything in the world. They don't need sleep and they're more talkative than usual. And then the low mood is where we see individuals experiencing those depressive symptoms. So oftentimes what we do see within here is that these individuals may experience psychotic features such as hallucinations and delusions that may also be present. So it's sometimes misdiagnosed as schizophrenia. About 10% of cases have rapid cycling bipolar disorder that's characterized by at least 4 mood episodes every year. It's very hard to treat and more common in women. So with bipolar disorder, we often have a misconception or call people, oh, that individual has bipolar disorder because 1 minute they're up and the next minute they're down. That isn't what bipolar disorder is. Even in rapid cycling bipolar disorder, that is where we see at least 4 mood changes in 1 year. So maybe 2 high moods or mania and 2 low moods or depressive episodes. And so what we see is that bipolar tends to be persistent, and it's kind of interesting that significant minority of people with bipolar are outstanding in some kind of way. It's actually noted or thought that these individuals actually experience bipolar disorder, and these include Abraham Lincoln, Winston Churchill, and Theodore Roosevelt. In terms of biological factors that go along with bipolar disorder, among various mental disorders, bipolar has the highest rate of heritability, and biochemical imbalances may be involved, but specific neurotransmitters haven't been identified. Some researchers suggest low levels of serotonin and norepinephrine may contribute to this, but this wouldn't explain why lithium, which is unrelated to either of these neurotransmitters, often helps stabilize both depressive and manic symptoms, and this is like the frontline medication for bipolar disorder. In terms of psychological factors, stressful life experiences often precede or occur before manic and depressive episodes. So severely stressed patients took an average of 3 times as long to recover from an episode than did patients not affected by stress. So again, we see a very big influence or impact of stress on psychological disorders. And so here we wrap up this lecture talking about this chart that we see on the slide. So this actually gives us a snapshot of what bipolar may actually look like. And so on the y-axis we can see individuals about a 7 or 8 where they feel like that's their normal attitude. So I'm here, I'm not feeling sad, I'm not feeling great, I'm just, my normal self. I'm cool, I'm relaxed. Whereas a 0, as you get closer to 0, you're experiencing a true depressive episode, and then 10, you're just in above, you're off the charts, and we would explain that as manic type of episode. And so we see on the x-axis, the 1 through 23 may be in terms of weeks. So in week 1, where were you experiencing in terms of mood? And so as the weeks go on, we see a depressive episode on week 8, lasting until about week 11, so 4 weeks, and then it goes back up to normal. And then we see a spike in there, and I would say even just looking at this would be more of a rapid, because that individual was going from down really low from a depressive episode to regular, and then just spiking out the chart with a manic symptoms. And so this kind of gives you a snapshot of what it actually looks like for an individual to be experiencing this type of disorder, bipolar disorder. And so with that wraps up the second part of lecture.